and breathe. Welcome to Calm Club, Anxiety UK's podcast. I'm delighted today to have with me Professor David Baldwin from the University of Southampton. David is one of our clinical advisors here at Anxiety UK, and is a great help to us when we have queries and questions around generalised anxiety disorder in particular, and the different treatment types. And we want to talk today specifically around those different treatment types. Is talking therapy the best solution? Is medication a good solution? Is a combination of both? Because I know many of our listeners do worry about these things and often call us and contact us asking what's the best treatment. And I think delighted to have David with us today to give us a bit more of an insight into that and hopefully to help you understand the different options available. So David, thank you for joining us, and delighted you were able to come and talk to us today.
Well, thank you very much for the invitation. It's a real pleasure to do this for Anxiety UK. As you say, I've been linked to Anxiety UK for about 20 years now as a medical patron, and I'm always impressed by all the work that they do to support people with anxiety disorders, and help them sort of understand their conditions and seek out the best forms of treatment. So I'm a professor of psychiatry at the University of Southampton, and I've been based at Southampton now for almost 30 years. So like most clinical academic doctors, my week is kind of divided into two parts, really. So one part's to do with research and teaching, in my case into anxiety and depression. And the other half of my week is spent running a clinical service where I see patients as outpatients, and they're referred to me usually by other psychiatrists for second opinions, but also by local GPs. So I've been researching into the causes and treatments of anxiety and depression since 1988. But my main research has been into treatments, but I've also, increasingly interested in causes of anxiety and depression too.
And over those that number of years, David, and that detailed research you've been doing, you must have had some incredible insights particularly into the causes of anxiety and depression, and they learnt a lot over that time. What can you share with us around that?
Well, people often ask me, so what's the cause of anxiety or the cause of depression? And the longer I've been working, the more I realise that there are multiple causes. So we're recording this on a Thursday afternoon. On Thursday morning, I do an outpatient clinic, and I saw 5 people this morning. And in each of them, actually, what's caused them to become affected by anxiety or depression has been the combination of a whole range of factors. So some early in life, people have had sort of bad experiences in childhood or in their teenage years. Some people have always been a bit anxiety prone by nature, by sort of personality, always tending to worry about things. Others, bad things have happened to them. You lose a job, your marriage breaks down, you become bereaved, you're coping with chronic difficulties in the family, like, illness in a partner, or chronic uncertainty about employment and money. And it's usually, to be honest, it's usually a combination of multiple factors that eventually kind of tip someone over the brink to go from coping reasonably well to coping less well. And the idea of treatment is really to get people back on course. So, to manage down the symptoms that they might have, to manage down their distress, and just help them to pick up the things that they used to do, to kind of put them back in touch with their own kind of resilience to adversity. So treatment, therefore, involves many different approaches. It's not a simple fix because the causes are all complex. The treatments also have to be quite varied. Yeah.
That's really interesting. I think picking up on the one point you mentioned there about it being sometimes just inherent in us. We often hear the phrase that oh yes, I'm a born worrier, and I know there's a big study going on. I don't know if you're involved in that, David. Being led by King's College London, I believe.
Yes.
GLAD, the genetic links,
study.
yeah.
That's right.
And I think that's fascinating, and one I often quote when I'm doing training sessions and when I talk about the causes is that genetic link and try to identify that. But
I think genetic influences on anxiety and depression are definitely there. Having a strong family history of anxiety or depression does confer an increased risk to the individual. But we're increasingly interested in what's called, epigenetics. So it's the interaction between a genetic vulnerability and environmental risk factors like adversity and bad life events. So, the genetics kind of create a risk, but then for that risk to be expressed, lead to an anxiety or a depressive disorder, usually other things have to happen on top. Having a simple genetic risk is probably not enough to explain why it is that some people become affected in this way.
I've just recalled as well, I can remember a number of years ago, I think 6 or 7 years ago now, when myself and Amo came to a conference at University of Southampton, and you were hosting, and one of the speakers, I think, was an American student who was talking about, I recall, he was talking about there'd been some research into our DNA and how they could identify people that would be more potentially susceptible to PTSD. And how the US Marines had used that to identify those people that were more likely to experience those kind of traumatic.
That's right. Yes.
And as a result, we're placing them in the battlefield in a way that reduced their likelihood of being exposed to trauma.
That's right.
That's one that's always stuck with me from that event that you hosted.
That's right. That was Michael Breen, actually. He was within Southampton with us for a few years, a very bright young man, very bright. He then went off to Mount Sinai in New York and has been continuing that research stream. He's particularly interested in genetics and acute stress disorders and PTSD, and thinking about how we can kind of protect people from the adverse consequences of trauma. Yeah. But
then we've got other factors, as you rightly say, and identify. I mean, we've not long come out of this period of the global pandemic, and that caused a lot of increased levels of mental health in a whole raft of people, didn't it? They having to live through a pandemic, having to be isolated and in lockdown, and cause it. And now we've got this whole cost of living crisis, the pressure on people's finances. We've almost got this perfect storm, haven't we?
Absolutely. I think the UK has actually been particularly badly affected compared to some other European countries. And of course, there are other reasons for that as well. But the pandemic was pretty corrosive in terms of people's mental health. There were lots of studies conducted looking at how people responded to the pandemic and to the lockdown and to all the losses associated with the lockdown and the illness itself. And yes, anxiety and depressive symptoms increased a lot in terms of the proportion of people with those symptoms. And things have improved a bit, but obviously there are a group of people that were badly affected by the infection itself early on, and now have, I suppose, what's called long COVID or post-COVID syndromes, and anxiety and depression is part of that. So there was a whole new sort of cohort of people who maybe had not been affected by anxiety or depression early in life, and who now were. And certainly we noticed that locally. In parts of the UK, referrals to mental health services have gone up 30% compared to before the pandemic. And most of this additional work in terms of new patients, most of it are people who have been affected by anxiety and depression.
And faced with those challenges, faced with that increase in demand on services, what can we do? How can we? What treatment options are available? Are they all? What would you advise in terms of?
It's hard to say that there's been a positive side to the pandemic, but there probably has in one respect, in that we're much more used to offering treatments online and kind of digitalized health interventions. So by necessity, suddenly we were moving to kind of computer-based appointments. Computerized cognitive behavior therapy, CBT, had been around for quite a while, but never really delivered at scale to large numbers of people. And very swiftly, in the UK at least, we learned how to offer effective psychological treatments online. And the IAP services, which are the improving access to psychological treatments, were really speeding ahead with this approach. So they're psychological treatments linked to GP surgeries. They responded very swiftly to the pandemic. And even, in psychiatry outpatient clinics, we learned, you didn't need to bring people up to a clinic, which might be a long way away from home, that you could actually have a video consultation very easily. No real loss of quality of the interview. A lot more convenient for many patients. They didn't have to travel long distances and for long periods. So actually, we're able to see more people through this development of online consultations. But people, nonetheless, often miss that sense of kind of physical and face-to-face contact with an individual.
That's an interesting point, actually. I sit at a stakeholder group that NHS England host every quarter, and we had a meeting actually only yesterday, where we look at IAPT, as you mentioned. It's actually just been rebranded, hasn't it? NHS Talking Therapies for Anxiety and Depression. They're trying to they're still rolling that out, so it's all a bit new. But we were looking at some of the data what happened during the pandemic and now post-pandemic, where they are trying to go back to offering that face-to-face option and choice. And I get that, and I understand we've always been very pro-choice. But as a result, some of the waiting times, some of the access times are actually dropping again, because they're obviously taking a bit longer to get done. And therefore, that's a real sort of quandary between, do we stick to going online because it's quicker and it's more effective in some cases, and the efficacy of it has been proven to be just as productive for the client, for the patient.
That's right.
It's a difficult balance, isn't it? But so apart from the sort of professional interventions, whether it be that talking therapy or medication or a combination of both, what would you advocate and support and encourage and advise people to consider in terms of just broader well-being and self-help tools that they can turn to? And often they find that there's a bit of a wait to get onto a talking therapy program. Any tips?
Well, I'm always impressed by the guidelines that were produced in 2015 for general practitioners working in the United States, actually. It was just a very simple, short set of guidelines. And the first step for them were simple, kind of non-specific interventions. So, you've got someone, if you imagine yourself as a GP and someone sitting in front of you with, anxiety symptoms, what's the first step? And the thing that they encouraged, really, and it might sound a bit nerdy, is first of all to rate the symptom severity using a scale. And they recommended something called the GAD-7, which we use an awful lot in the UK. So the General Anxiety Disorder 7-item scale. Although it's called the GAD-7, actually, you can use it across all anxiety disorders. So just rate the symptoms so you know which symptoms are most troublesome and get a sense of the overall severity. In the way that we would measure someone's blood pressure, if they've got symptoms suggestive of a heart disease. So that was the first thing they recommended. And then following on from that, really quite simple things like reducing the consumption of caffeinated drinks. So reducing your coffee, tea, and Coke type drinks.
Other energy drinks are available.
Other energy drinks, yeah, indeed. But to reduce the consumption of that is important. We're increasingly interested in the links between the gut and the brain. And there's no doubt that having a healthier diet with more vegetables, more fruit, less processed foods, can have beneficial effects on mental health. So at least encourage people to think about their diet and whether they could, if they're able, and it is the financial consideration as well, if they can move to kind of healthier ways of eating. If someone's drinking more than they should of alcohol-based drinks, then clearly they will benefit from reducing their alcohol consumption. The same is also true of smoking. It's very interesting when people say, well, I smoke because I feel stressed and it relieves stress. And the evidence is kind of to the opposite, really, that when you're feeling stressed, it's because you're withdrawing from nicotine, and the nicotine is helping to relieve those withdrawal symptoms. But if you manage down your cigarette smoking, it can actually often be helpful in reducing anxiety and depressive symptoms. So those very kind of simple lifestyle interventions combined with things like mindfulness-based techniques, mindfulness-based stress reduction, learning muscle relaxation techniques, involvement in things like yoga and Pilates and meditation. All of those things can be helpful and probably are helpful to about 50% of people, about half of people, which is fantastic. But of course, then there's the half that who've tried these things and they're still quite troubled by anxiety and depression. And the question is, what do you do with them? And just to kind of introduce the subject, I mean, if people have got, symptoms above a certain severity which haven't responded to those kind of lifestyle interventions, and if the symptoms cause a lot of distress and upset, and they're kind of stopping people from doing what they want to do, they probably will benefit from some form of treatment, which would be either psychological or pharmacological, or the combination of the two.
And how do we, one of the things we struggled with, and we have talked about quite frequently internally, is people will often ask us, well, what do you think, I'd ask, what course of treatment do you think is the best, or what would you recommend? And it's very difficult to advise, isn't it? Yeah. And we've often said, wouldn't it be wonderful if we had a tool that could measure client A is going to benefit more from therapy, client B is going to benefit more from medication, and client C would benefit more from a combination. And we don't have that magic wand at the moment, and we'd love to have one and some kind of algorithm these days with AI and all the rest of it. But we're not there yet.
We're not there yet. No.
And we get a lot of people say they don't want to take medication because they have a fear of becoming addicted to certain forms of how do we find the right balance of treatment, the most suitable treatment? Any thoughts or suggestions on that?
Well, we thought about this when we were writing our guidelines for the management of patients with anxiety disorders through the British Association for Psychopharmacology, the BAP. Now, its title suggests that we'd be very, very preoccupied with drug treatments, but actually we looked at all the data that was available at the time and were very clear in our guidance that patient preference is key because the evidence is strong for certain drug treatments and it's strong for certain psychological treatments. And when we looked at it, a similar proportion of people responded, and the people that did respond kind of responded to the same degree. So we felt actually it was perfectly reasonable to say that the patient preference is the most important consideration.
That's really interesting.
Yeah, but now at the time, that was considered a bit controversial because waiting lists for psychological treatments were really quite lengthy. But as you've said, with the rollout, so that psychological treatments are more readily available in primary care, waiting lists have come down. I mean, it's still, there is time that you have to spend before you can start treatment, and that is different to a GP prescribing a pill where you could start treatment on the same day. But certainly getting access to psychological treatments is somewhat easier than it used to be. It does vary around the country, but it is easier than it used to be. So we take account of patient preference. Guidelines from NICE, the National Institute of Clinical Excellence, they tend to say go for psychological treatments first, and then if someone doesn't respond or just can't sort of get their head around it, think about pharmacological treatments. I think that's perfectly reasonable to state that, but there are certainly many people who, can't tolerate a long wait and have tried psychological treatments in the past and found them really difficult. So there'll always be a group where you're thinking that a drug treatment might be the kind of probably the more easily implemented first-line treatment.
Yeah. And that's it's really, really valid point, David. I had a question there that as you were saying that, and I think that it's just disappeared briefly, but it'll come back to me, I'm sure. But
for sure it will. Yeah.
I think it was to do with it's not coming. It's not coming. But
right,
bit fascinating. Sorry, go on.
I could go on to talk about the psychological treatments that are effective in generalized anxiety disorder, and then go on to talk about the drug treatments if you'd like. I mean, in terms of psychological treatments, there's really strong evidence for cognitive behavior therapy and for applied relaxation. So there are lots of what are called randomized controlled trials. And then there are what are called meta-analyses of randomized controlled trials, where you take all the data from all the trials together and come up with a kind of overall view. And these big picture meta-analyses certainly suggest that CBT and applied relaxation are very good psychological treatments. Sometimes the CBT needs to be combined with additional approaches, maybe mindfulness-based approaches, or incorporating elements of what's called, acceptance therapy, learning people learning to be a bit more self-compassionate as well as an additional component to a psychological intervention. But they certainly work in the short term. And if people respond to treatment, the response is very often maintained for many years. So, there's a few psychological treatments which are certainly effective. And then in terms of drug treatments, most guidelines would suggest that the first line drug treatment is from a class known as the selective serotonin reuptake inhibitors, the SSRIs. There are about 6 or 7 SSRIs which have been shown to be effective in generalized anxiety disorder. So they tend to be the first line drug treatments, but there are other classes as well, like the serotonin noradrenaline reuptake inhibitors, the SNRIs. They tend to be used when people haven't responded to an SSRI. And then there are other drug classes as well. But most guidance suggests that if someone hasn't responded to 2 evidence-based treatments, which could be a drug treatment or a psychological treatment, or 2 psychological treatments and 2 drug treatments, but when people haven't responded to 2 treatments in general practice setting, they should be referred to the mental health services. So, and it's in that setting that the additional types of drug treatment probably be used.
That was really good, David. You managed to answer the question I couldn't remember without me even. It was about the modality, the type, what type of therapy, CBT or so. What you talked about there, that's what I was going to. That's what I was struggling to remember. I was going to ask, but that's been really good. Oh, excuse me. David, I think that's been really, really insightful and
thank you.
Really, really interesting. I'm sure many of our listeners will go away and consider what they've heard, having listened to this, and be better informed as to what kind of treatments that they can consider and ask their GPs about, or what kind of other activities, as you say, the other tools that we can look at, our diet and exercise regimes, etc., would be really beneficial. Is there anything else you wanted to highlight?
Maybe I could talk a little bit more. You can edit this out or edit it in just as you wish, but maybe just talk a little bit more about drug treatment actually with SSRIs. It might be, you might include that. Yeah,
please do.
So I'll just go ahead. Okay, so the as I said, the first line treatment tends to be an SSRI, and there are a few things to kind of know about this. So if you're going to start a treatment with an SSRI, then in the first week of treatment, a proportion of people will actually feel a bit more anxious, okay? They feel a bit more nervy and a bit more anxious. And you think, oh no, it's the conditions worsening, or the treatment's making me worse. And it is a proportion. It's about 25% of people do feel a bit more nervous in the first week. What you do in that situation is, if it is in the first week, it tends to peak, this kind of increased nervousness, at about day 3 or day 4. So just stick with it. Don't increase the dose, but just stick with the current dose. And then usually by around about day 7 or day 10, that increase in anxiety has gone. And it's from round about day 10 that the drugs are really beginning to work. From what are called placebo-controlled trials, you see the difference between the drug treatment and the sugar tablet. You see the difference at round about week 2, and it's certainly stronger at week 4. So give it time. Now, in generalized anxiety disorder, if actually you've been taking the treatment every day for 4 weeks and you're absolutely no better compared to how you were at baseline, the chances are that you're not going to respond to that treatment at that dose. So most of the guidance says people should be reviewed at 4 weeks, okay? Because if there's no sign of improvement at week 4, then you need to have a conversation with the doctor about what to do. It might be increasing the dose. It might be adding in a psychological treatment. It might be thinking about other things which could be causing you to remain anxious. But certainly 4 weeks is long enough to know what the likelihood of responding is. So that's the first point I wanted to make about drug treatment. The second is about other side effects, okay? And unfortunately, the most common side effect with the SSRIs is a reduction in sexual interest, which, is really quite bothersome to many patients. They're beginning to feel better, less anxious, more self-confident, looking to enjoy a relationship, and then find themselves not able to enjoy it as much as they used to. And this can cause some people to stop treatment. It is worth having a discussion with your doctor about this, because this kind of sexual side effects of SSRIs are often dose related. So actually a reduction in dosage, you can keep the anxiety symptoms under control, but your sexual interest can get back to what it was. So that's, a really important side effect. The other one is, as time passes, and maybe people are feeling a lot better, you can gain weight with SSRIs. We didn't think that you could originally, but you can. People with long-term treatment, most people will put on a bit of weight. It's not that much, but that can be bothersome to people. But there are alternatives to SSRIs which are less likely to cause weight gain. So if you're bothered about gaining weight on an SSRI, do go to talk to your doctor about that, because there are alternatives. And then the final point is, when it's time to stop treatment, don't stop it abruptly. People do sometimes. And of course, sometimes they go away for the weekend or something to stay with family and forget to take their medicine with them. And therefore, stop their treatment sort of abruptly, not by design. Don't let your treatments run out, and don't stop them abruptly. When it's time to end, the dose needs to be reduced gradually over time. Now, how long that should be is debated. In our guidelines from the BAP, we actually recommended 3 months. Now, that was a recommendation that was made about 10 years ago, and to be honest, there wasn't much evidence to support that. We felt that was probably just on the basis of clinical observations. That was about the right thing to do, about steadily reducing over 3 months. But actually, the research evidence as it's come through suggests that, a few months is probably the right period to be reducing the dose. So, and that should be done in discussion with your doctor. So, obviously that you need to continue with treatment beyond the period when you feel you're back to normal. And most people would recommend about 6 months of that kind of continued treatment. But when you get to the end of that, have another discussion with your doctor about how to reduce treatment steadily to prevent these kind of quite troublesome discontinuation or withdrawal symptoms. Yeah. That's, I think, key things to remember about drug treatment.
David, that's fantastic. Just picking up on the 4-week review thing from the start, is that something most GPs would automatically plan and schedule in and encourage you to book in to do that, or is it something that you need to be managing yourself and making sure you remind your GP that you need to have that review?
GPs are recommended to review patients early when starting antidepressant drugs, particularly younger people under the age of 25, because that increased nervousness, which I mentioned, is more common in younger people. So GPs are encouraged to review. And most GPs would actually review patients at 4 weeks, because the first prescription tends to be for 28 days. So that's actually a convenient time. I did say that's for GAD. I have to say, for other conditions like obsessive compulsive disorder, OCD, 4 weeks is not long enough. You need to allow longer to know whether or not a treatment's worked. In OCD, there are patients who've been taking treatment for, say, 8 weeks who don't appear to be getting better. And then at 12 weeks are. Most people would say probably 12 weeks is the right period in OCD to review whether or not something's working. So it does vary from one condition to the next.
That's really useful. Thank you.
Yeah,
I'm sure that those listeners will listen to this, will take that on board and have those conversations at the appropriate times, I hope, and that'll be beneficial for them to know that. That's great, David. It really has been wonderful listening to you, and helpful for me to remind myself about some of these things that we can remind our members about when we're talking to them on the helpline or whatever. But hopefully those that are listening to our podcast will really benefit from that insight that you've provided with us today. That's really been fantastic. Thank you so much.
Well, thanks, Dave, and it's, as I said at the beginning, it's such a privilege to be able to be a patron for Anxiety UK. It's a wonderful organisation. You do such good work with people up and down the country, and undoubtedly many thousands of people have benefited from everything that you do over the years. So well done, and thank you.